Hello, thank you for inviting me to speak about our telehealth outcomes and research. I'm Kate Minick. I'm the Director of Research for Rehabilitation Services at Intermountain Healthcare, and I'd like to thank my colleagues for their contribution to this work. Stephen Moffat is our Director of Outpatient Rehabilitation, who took it upon himself in the middle of the initial COVID surge to start manually collecting the data that I'm using while we modified our data systems to differentiate telehealth visits. Devin Woodfield is the analyst for rehabilitation services at Intermountain and has the same passion for outcomes that the rest of us have. And Stephen Hunter is our director of internal process control, who has been leading out on the implementation efforts around telehealth at Intermountain, and without whom no quality improvement of any quality happens. Briefly, let me introduce Intermountain as a not-for-profit integrated health system based out of Salt Lake City, known for high-value care and low costs, with 23 physical hospitals and an additional virtual hospital, an integrated payer, and about 35,000 caregivers, 1,500 of whom belong to rehab services. We also utilize Intermountain ROMS, a web-based application and analytic system which serves as a central repository for patients' self-reported pain and disability measures, and now holds over 2.5 million patient-reported outcomes. While ROMS has recently expanded into home health, neuro, and with other rehab providers, because our data collection and outpatient ortho physical therapy is the most robust, that is what I used for the analyses that I'll talk about today. I'm going to discuss the utilization of telehealth visits and the virtual collection of patient-reported outcomes that began for us and many others at the start of the COVID-19 pandemic. It was March 17th that COVID disruptions hit our health system, and like others, we began offering telehealth services despite a lack of infrastructure and amid an uncertain reimbursement environment. At Intermountain, in-person therapy appointments remained available throughout varying stages of restriction, although at a reduced capacity, and telehealth virtual visits via phone or video were offered as alternatives, particularly for patients who are at high risk for COVID complications. Restrictions for us lasted until the end of May 2020. After that, while COVID screening was still in place, there were no limitations on in-person visits. For this talk, I'm going to take you through 3 separate analyses. First, a basic description of the telehealth care provided in April and May 2020 and our collection of patient-reported outcomes. Then a comparison of telehealth to in-person treatment in those same months. And finally, an update on the data since this analysis was completed last summer. For patients treated in April and May 2020, we analyzed patient visits at 16 outpatient physical therapy clinics. Specifically, we looked at the type of delivery, in-person versus telehealth, and whether or not a patient-reported outcome was collected. We also used a logistic regression to predict the use of telehealth as part of physical therapy, with age, gender, initial outcome score, and initial pain score as independent variables. Now, just to clarify, this telehealth group includes anyone who received at least one virtual visit during their episode of care. Since in-person care did not shut down entirely, there were not enough patients who had their entire episode delivered virtually to have this as its own separate group. Overall, 29.7% or 688 visits were provided via telehealth during these 2 months. You can see in the pie chart that of the telehealth visits, over half were for lower extremity or upper extremity conditions. Just over a quarter were for back pain and only 9% for neck pain. Now, we highly value the collection of patient-reported outcomes on every patient at every visit to inform clinical decision-making and track progress over an episode of care. You can see that during these 2 months, for the 1,631 patients seen entirely in person, the collection of patient-reported outcomes at every visit was over 97%. However, for the 688 visits conducted virtually, only 11% had an outcome associated with it. Now, this is a little unfair to judge in the middle of a crisis response and sudden transition to a new method of care delivery, because there was no platform to collect these outcomes virtually. There was no front desk, no electronic method of collection established, so it relied instead on the therapist helping the patient complete the outcome during an already challenging visit session. So this is not an indictment of the performance of our therapists, but rather it highlights the need to establish methods of collecting patient-reported outcomes alongside virtual visits, since the methods we used in the clinic did not translate. Finally, we conducted a logistic regression to predict telehealth utilization during the episode of care from age, gender, initial outcome score, and initial pain score, which was statistically significant with a chi-square of 39. Every increasing year of age was associated with an increased likelihood of utilizing telehealth, and women were 1.3 times more likely to use telehealth compared to men. This may be related to health system restrictions put in place during the spring of 2020 that recommended limited access to in-person treatment for patients at high risk of COVID complications. So what we learned from this first analysis is that 30% of our visits were virtual during our period of highest COVID restrictions. Telehealth was used most frequently for extremity visits. Older patients and women were more likely to use telehealth, and there were significant barriers to collecting patient-reported outcomes virtually. So for the second part, I'm going to compare the differences in patient-reported outcomes and visits utilized by patients with at least some telehealth treatment compared to patients who continued only in person during the same months of April and May 2020. For this analysis, data were gathered from the same 16 outpatient physical therapy clinics, but this time we included only patients who were discharged by the end of June. And we included only patients with at least an admit and discharge patient-reported outcome, which reduced our N to 433 patients. Patients were categorized the same, receiving a telehealth hybrid or receiving only in-person treatment. Patients completed patient-reported outcomes throughout their episode of care consistent with their condition as listed here: the modified low back disability, the neck disability, the quick DASH, knee outcome survey, and the lower extremity functional scale. A Welch's t-test for unequal variances was performed on the outcome differences between those receiving telehealth compared to those receiving only in-person treatment for each of the 5 patient-reported outcome tools. Additionally, Welch's t-tests were also used to compare the number of visits and overall length of stay. Of the 433 patients, 293, or 68%, received only in-person treatment, and 140, or 32%, received at least some virtual care. On this chart, you can see the distribution of telehealth in blue compared to in-person treatment in gray for each of the 5 patient-reported outcomes. Interestingly, telehealth was used equally about a third of the time across most of these conditions, and just slightly higher in the upper extremity at 37%. Patients using telehealth were significantly older than patients receiving in-person treatment, with a mean difference of 5.7 years. There were no differences in gender between telehealth and in-person. So patients utilizing telehealth experienced a slightly longer length of stay, with a mean difference of 11.7 days, and a slightly higher number of visits by an average of 0.87. There were no statistical differences in outcomes for patients treated for low back, knee, or other lower extremity conditions. I used a box and whiskers plot here to show the median and quartiles of the outcome difference scores, with in-person treatment on the left side of each plot in blue and telehealth treatment on the right of each in green. There's a faint X also on each plot to indicate the mean. None of these differences appear to be clinically meaningful either. However, for patients with upper extremity and cervical conditions, there were significant differences on the quick DASH and neck disability index, suggesting that patients who had telehealth visits incorporated into their care plan actually did better than those that had only in-person treatment. Now, there were a lot of questions at this point about what was driving this difference. We could only speculate, but it's possible that given the pandemic, the patients who utilized telehealth already had an established treatment path that was working, and they felt comfortable with their improvement so far in order to engage in telehealth. Or stated another way, perhaps patients who were not doing as well felt they needed to be seen in person. Or maybe the care via telehealth was just fundamentally different than in-person care. The nice part about standard outcome collection is that we could keep an eye on this as things returned to our new normal. So what we learned from the second analysis is that while the use of telehealth led to a modest increase in the total number of visits and a longer length of stay, patients experienced similar or improved outcomes. Even though we saw a slight increase in the number of visits, and even though this usually means higher costs, it turns out that while we averaged 3 units billed for in-person care, we only averaged 2 units billed per telehealth video visit, and just 1 unit for a phone-only visit. So in this sample, the telehealth patients likely did not have increased costs. So finally, I'm going to talk about current updated data since those analyses were conducted, updated through mid-March 2021, so exactly a year since the pandemic disruption first began. Since then, we've conducted over 8,500 telehealth visits. Now, this graph includes all telehealth visits, including those conducted by speech therapy, which is a large percent, occupational therapy, and pediatrics. So to keep this apples to apples, I'm just going to talk about the outpatient ortho physical therapy visits, which totaled 4,169 for the last year. As you can see, the volume trend here follows the same pattern as the total number of telehealth visits. So on the left is just a reminder of our April and May 2020 distribution of conditions seen. On the right is the updated data set. No major changes here, just a shift of a few percentage points here and there. Overall, we are still seeing about the same distribution of extremity and spine conditions. If you remember that in April and May, about a third of our visits were conducted via telehealth across the board. Here you can see that proportion has dropped significantly since the spring. Now only 6 to 15% of each condition is seen virtually. Upper extremity conditions make up our largest volume of patients in total, but the lowest percentage of those patients utilize telehealth compared to other conditions. I didn't separate the data out here, but I suspect there are probably differences in surgical and non-surgical patients for each of these groups, and maybe why this was our highest percent in the spring when elective surgeries were suspended. On this graph, you can see the number of telehealth visits conducted in the dark blue bars, a lot in March through May, and less once restrictions were eased. The light blue line indicates the percent of time that a patient-reported outcome was collected at the telehealth visit. You will remember that we averaged just 11% in April and May due to the challenges with collecting them virtually. Last spring, we began working with our developers on an option to email the patient-reported outcome to patients in advance of their visit. It took 8 months, but that finally made it through cybersecurity review and was implemented in January. Clinics also found interim processes that improved collection rates as well. So while we're still at a rate less than our in-person collection, I'm proud of the significant improvements that our clinicians made on this metric in a challenging year, and it should only continue to get better. This table shows a demographics breakdown of the updated data set. Age is no longer significantly different between telehealth and in-person, but gender is now significant with a higher percentage of women in the telehealth group. The length of stay is still longer for telehealth and about twice as long as it was for the April-May data set when it was just over 11.5 days. In talking with some of our providers, it sounds like they have started to leverage telehealth for opportunities like booster sessions when they normally may lean towards not seeing a patient at all. And this might be driving the longer length of stay. And finally, visits are still significantly longer for telehealth by the exact same amount as the original data set. But the billed procedures are still lower for that group, so this does not necessarily mean higher costs. And finally, looking at updated box and whiskers plots with in-person on the left in blue and telehealth hybrid episodes on the right in orange, the mean difference for the left lower extremity, knee, and low back disability continue to show no statistical or clinically significant differences between the groups. And while the quick dash and neck favored telehealth in the April and May data set, that washes out here with no significant difference between the groups for our upper extremity and neck populations. So the take-home message here is that when telehealth was utilized as part of an episode of care over the last year, while there were some differences in who opted to participate in telehealth, particularly women, and during periods of higher COVID restrictions, also older people, overall, there were no worse outcomes with telehealth, which I think was an initial fear for many providers and patients. We do see a slightly longer length of stay, which may be related to how providers are choosing to incorporate telehealth into their care plan, and a slightly higher number of visits, though we don't believe it increased overall costs due to lower billed procedures for telehealth encounters. Ultimately, telehealth is proving to be a really useful tool for us long-term in order to improve care for patients that otherwise may not be able to engage in rehab. Thank you. I appreciate your time today, and I'm happy to answer any questions.